Okay, hi everyone. Welcome to our very first webinar for this year, and it's going to be a COVID update. And I am very grateful for our panelists that's joining us today. So we've got a broad range of people that we're going to speak to, and as we come at the end of this fourth wave of COVID infections, I think it's very important for us to look back. Hi everyone, welcome to our very first webinar and see what has happened. Sorry, COVID update. Sorry, I've got some technical difficulty here. That's joining us today. So we've got a broad range of people that. Okay, sorry about that. YouTube is talking back to me. Okay, great. So I'm going to ask Mignon. So we all know Mignon very well. She is part of the SAPA exec. She's a nephrologist. She's an intensivist. And through this COVID pandemic, she's really led the way for a lot of pediatricians and for schools and just in general advocated for children. So I just want to, she's going to be part of our panel, and she's also going to introduce two of our other panelists to us. So thank you so much, Mignon, for joining us and for all your expert advice that you've given through these waves.
Thank you very much, Marty, for having me, and thank you for organizing this very exciting webinar. I know COVID's been pretty awful for everybody, but it has had some advantages in that we've actually been able to meet together as pediatric colleagues, not just in South Africa, but across the world. And really very, very grateful to Professor Andrew Pollard, who's the director of the Oxford Vaccine Group, for joining us. Andrew and I worked together many, many years ago in pediatrics. So great to see you again, Andrew. You look the same age as all that time ago, and we really look forward to your wisdom. Also, a big thanks to Waasila Jassat, who is a public health medicine specialist, and she's the lead for DATCOV on the National Hospital Surveillance COVID-19 from the National Institute of Communicable Diseases. And I think Waasila has crunched numbers like no one I've ever come across. She's really been amazing. And often when I've been up late at night sending emails, hers comes back in a flash. So really grateful to the two of you for joining us. And we're going to start off shortly. Thank you, Marty, for running with us.
Okay, great. So I think the first question I want to ask, mainly to Dr. Jassat and to Prof Pollard, is, so we've been through this Omicron, and obviously South Africa made some good and bad news when we identify it for how good we are, but also then it affected a lot of how we functioned, and it also affected a lot of how we were dealing with the infection because it was so rapidly spreading. So I want to ask, after this wave, what do we know about Omicron, and how does it behave differently in children than the previous variants? And maybe I can ask Prof Pollard first.
Thanks very much for that question and for inviting me to join the webinar today. So far, our experience here in my own clinical team in Oxford is that Omicron has, as with COVID in general, in terms of acute disease, has been rather mild in children. And we do have clearly children in hospital, but largely we think with incidental infection. So, you know, I think that general view that Omicron is milder seems to be true in the UK, as was first described in South Africa. And the wave of disease from a hospital perspective does not translate into a large number of hospitalizations with Omicron. I think what is perhaps different about Omicron from previous waves is its extraordinary ability to spread. And so the rate of positivity in the community has been extremely high. But interestingly, here in the UK, that was particularly focused on younger adults initially. And it's only now, during January, as all the schools have gone back, that we're seeing very high rates of spread in children. So it may be that for us, although we've seen plenty of cases in the community, that there's many more children still to be infected in the current wave.
Waasila, can I maybe ask you, what is your impression of how Omicron was different in the South African population of children?
Yes, and I hope you don't mind. I'd like to share a few slides so I can quickly answer that question. So these are data that comes out of our data hospital surveillance for COVID-19. Just to remind everyone, we've now seen the end of the fourth wave dominated by Omicron. And just before the fourth wave, we had a reported seroprevalence of over 70% measured in Gauteng community study and vaccination coverage of about 40% of adults in November. And also to just note that we had no increase in national restrictions during this wave. And yet we saw this decoupling of cases, admissions, and deaths, where when we look at the percentage of the Delta peak, we saw that the cases peaked at 110% of the Delta peak, admissions at 67%, and deaths at around 20% of the Delta peak. And we even saw that there was no significant rise in excess deaths like we saw in the previous waves. And in fact, it also seems to have started coming down in the last few weeks. So just in terms of severity, for all age groups, there was a lower proportion of cases admitted to hospital, less patients needed oxygen, less were classified severe, and less patients died in the fourth wave compared to the previous three waves. And in fact, when we do a multivariate analysis, we see compared to wave 4, there's a higher risk of severe disease in wave 1, 2, and 3. When we look at pediatric admissions, so this is cases, and what we see is in the fourth wave, most cases were highest in the 40 to 59 and 20 to 39 group. And amongst children, we did see that second peak in teenagers in the Delta wave. We saw admissions, cases higher in teenagers, even in the fourth wave. And the only difference was we saw more cases among 0 to 4 in the fourth wave compared to the previous waves. It's a big difference when it comes to hospitalization. So on the left, you can see that most admissions are in those over 20. But in this wave, we saw quite a large increase in the incidence of admission in children under 4. And just there, here you can see just pediatrics, and you can see the huge rise in the incidence of admissions in children under 5. So there was a lower proportion of adults admitted to hospital, the higher proportion of kids admitted to hospital. And we can see this way, in the first, second, and third waves, more adults were admitted, and in the fourth wave, more people under 40 were admitted. And yet for those under 20, even though there was a higher proportion of cases admitted, 9% versus 5, 4, and 3% in the previous waves, less needed oxygen, 12% compared to 21 and 18, less were severe, and less died in the fourth wave. Just looking at the under ones, which are slightly different to the rest of the pediatric population, there's this very curious picture of the proportion admitted being very high, well over 50s and 60s in the second, third, and fourth wave, which leads us to think that there's under-testing in the community of the under ones, and it's mostly those that are admitted to hospital that are tested. But even though there was a lot of under ones admitted, there was a lower requirement for oxygen, lower severity, and lower proportion who died in hospital. And what's also interesting is that while in all age groups there was a lower severity in the fourth wave compared to the previous waves, there is a tendency for higher severity amongst under ones compared to those 1 to 19 years. And the same are being seen in other countries. And just to remind us that vaccination coverage is much lower in children compared to adults. And even in seroprevalence studies showed seroprevalence of 56% for under 12 compared to 80% for those over 50. So we know that seroprevalence and prior immunity is lower amongst children. So we're definitely seeing a downward trend in the fourth wave, a decoupling in cases, admissions, and deaths, and health capacity was not reached in the fourth wave despite no increase in restrictions. We know that Omicron has a significant growth advantage. There's a high proportion of asymptomatic infection, higher secondary attack rates and reproductive numbers. And we don't believe that testing strategies, admission criteria, and treatment change between waves. And yet we saw less severe disease. Whether this is because of lower intrinsic virulence or immunity from prior infection or vaccination is the question. We know there's a shift in tropism of Omicron to the upper respiratory tract compared to Delta, which has an affinity for the lower respiratory tract. Studies have shown less severe pathogenicity in hamster models and lower cleavage efficiency. And in terms of even though there's less reduction in neutralizing titers for Omicron with primary vaccination series and prior infection, we believe that vaccine effectiveness is substantially higher against hospitalization than symptomatic disease. And particularly for children, while we saw more admissions, but less severe disease in children. And particularly in children under 1, there were higher admission rates and more severity than older children. Question is, were children more symptomatic because of their smaller upper airways and Omicron having a higher application in the upper airways? Children seem to be admitted more for fever, hydration, and seizures, but don't require oxygen and ventilation in this 4th wave. We know they have lower seroprevalence and vaccination coverage, but we also saw more incidental admissions, children admitted for other respiratory pathogens or other reasons, but tested positive incidentally for COVID, and possibly that we're underdiagnosing cases in the very young children because we're seeing that only children admitted to hospital get tested in the public sector. I'll stop there, and sorry for taking up your time showing you those slides, but I just thought it would help sharing some of the data as we answer these questions.
No, I think it's great. Maybe we can ask Prof Pollard if he wants to comment if he saw anything on these slides that is different from what happened in the UK.
No, but looking at the slides, it did make me reflect on what we understand by the data. And certainly here in the UK, the way that things are reported, hospitalizations are individuals who test positive and are admitted to hospital. So if you fall off a ladder and break your leg, you will be included in hospitalization data if you have to be COVID positive. And it's extremely difficult from a database analysis to separate out the complexities of a clinical diagnosis of what is actually COVID when you're reporting in real time. And I think that becomes particularly problematic, like now in the UK, where there's such a high rate of transmission. It means it's extremely likely that anyone admitted to hospital is positive. And we've had points of time where 1 in 20 or 1 in 15 people were positive in community surveys. So that means almost everyone admitted has a 1 in 20 chance of being positive. And that does really then start to skew the data to having a lot more incidental infection, including all the respiratory ones, as we were just hearing with co-infections with influenza. And whereas if you're in a situation where you've got a more aggressive virus and that is transmitting slightly less than this, it's much more likely that someone admitted actually has that disease. So we may be seeing this phenomenon in pediatrics, where there's a huge rate of spread, where a high proportion of those that are picked up in a database analysis are actually coincidental admissions with COVID, particularly given how mild it seems to be. And I think we really need to be in a position moving forwards with COVID, and this is beyond this wave, of having much more clinically driven analysis, where we stand at the end of the bed and decide whether someone has that as their primary diagnosis, to try and separate out some of these complexities. I have to say, from my own experience, sometimes it's quite difficult, even when you are there, to decide whether the disease you're looking at is COVID or not.
Yeah, no. Mignon, maybe I can ask you to now comment on some of the hospitalizations and ICU admissions that you know about.
So before we had the retrospectoscope and the wisdom of Waasila's fantastic data, we were really worried about what was going to happen in our ICUs. And so just to share 3 slides with you, we did a snapshot and we looked at pediatric admissions on the 4th of December. Across all the intensive care beds in the country, both private and state, for pediatric ICU. And you can see here in this column, we had only 12 kids in the entire country admitted who were COVID positive, but not necessarily sick with that. So quite a few kids had leukemia or they had a renal transplant. And so that was in the period on the day of the 4th of December, and then 6 weeks later, the 14th of January, again, the column over here, 21 cases. So we did have some kids with respiratory infections, but as you know, we do see quite a lot of trauma cases. So as Andrew said, somebody who'd fallen off their bike or somebody who'd fallen out of a tree or been knocked over by a car. A lot of those kids happen to be incidentally positive. We've even got a kid with Takayasu's at the moment who we're trying to get a scan for, but we can't because she keeps being positive for her COVID, but she's completely asymptomatic. Of the deaths we had, one was an acute abdomen with a very late presentation, and the one, unfortunately, we think was a MIS-C or a PIMS, but for the rest, really not many large numbers of children admitted to ICU, quite large numbers admitted to general wards, with some with respiratory or COVID-related issues, but on the whole, at least 50% were what we called incidentals. So that's just the point of view from our sort of message to the rest of the world is don't panic. There are not thousands of children being admitted to our ICUs.
Waasila, I want to ask you, I remember in the first 3 waves, you guys had both that beautiful data that suggested that it was adults kind of driving the pandemic, that it wasn't, that the children was never the index case. Was that the case for the 4th wave as well? Because I seem to have a lot of friends that the children got sick and then the adults got sick. Is there a different phenomenon that you guys are seeing, that children might be the ones that get sick first, or is it still the adults driving it?
I think it's difficult from our hospitalization data to infer, the transmission dynamics. But we did see earlier rise in admissions in children and in fact in infection in children in this 4th wave, then proceeded by rises in other age groups. But what was interesting in the 3rd wave, in the latter part of the 3rd wave, when schools opened, we saw a second peak amongst teenagers, and then we didn't see rises in other age groups after that. And similarly, just in this past week, we've started to see increases in teenagers again in SARS-CoV-2 cases in some of the provinces that opened schools in the last 2 weeks, and we haven't seen a reflex increase in adults. So I'm not sure if that is evidence to say that when we did see increases in children, we didn't then see rises amongst other age groups. And maybe what we saw in the 4th wave was actually a phenomenon that had started even before the wave began. There was a higher proportion of admissions amongst children just before, and that might be because of, we had a simultaneous peak of influenza A around the same time. And so for other reasons, because there were many incidental positives in the hospital at the time, I'm not sure that we can say that there truly was, a first increase amongst children. We know that the earliest cases in Tshwane in the beginning of the 4th wave was amongst tertiary education students, with small outbreaks in the universities in Tshwane, and then there were a few small outbreaks in schools as well. But yeah, I mean, I think it was just an unusual sort of evolution of the 4th wave. And I don't know that we have enough evidence to say that, children were more likely the vectors in this wave. We didn't seem to think they were in previous waves.
That's right.
Can I ask a question of Mignon? I mean, we've seen an extraordinary number of cases in children in the community, and I imagine the same has been the case for you in South Africa, but some weeks ahead of us. About a month later, you'd expect, if there was going to be a problem, to see a surge in MIS-C. And I just wondered whether that's happened. I mean, certainly we're at the point where some of that should be happening. We're not, to my knowledge, seeing that anywhere, certainly not locally here, which I think is also rather interesting, that there's this vast number of cases that are occurring in the community, and yet we aren't seeing a big increase in pressure on the system around the inflammatory condition. I'm just interested to know what your observations are in South Africa.
So Cape Town seemed to have quite a lot of MIS-C with the 1st, 2nd and 3rd waves, and our rheumatology colleagues both at Tygerberg Hospital and Red Cross across both platforms have actually written extensively about this. I think our numbers were 60 or 70, so pretty big numbers. They often didn't make it into ICU because we managed them really effectively and well in the high cares. And I must say, my heart sank when I heard about this new variant and that it was going to hit kids more. And we just thought, oh no, here we go again. But I'm touching wood and I'm crossing my fingers and toes. We have not seen a massive resurgence of MIS-C yet. Always nervous to say there definitely hasn't been, because this was only reported 24th of November. So I guess we still got another month to go before we'd know for sure. But we saw a lot in the 2nd and 3rd wave, and at the moment I'm not feeling, fingers crossed, that we're seeing as much yet. But I guess time will tell.
Which is actually very interesting from the biological perspective. It turns out to be true, and we know what the genetic variation in the virus is, and perhaps that gives opportunities to try and understand what is driving the inflammatory condition when we can look at that in more detail.
Yeah, I guess the other thing just to mention is that since then we have introduced vaccination for 12 to 17-year-olds, and we did have quite a few older kids, although there were quite a few younger ones as well. And question is, has the vaccine made any difference? We haven't had a huge number of kids vaccinated, but most kids have at least got their first vaccine, because for a while the government felt that only one vaccine was safe and two was maybe a bit concerning. So I guess the answer to that is watch this space, but hopefully not.
Okay, so I think that gives us a great overview of the numbers and the hospitalizations. So now I would like to go and speak a little bit about the COVID vaccine in children. So one of the hot topics, but maybe before we go there, I just really want the participants that if you've got any questions, please post it in the chats or post it in the Q&As, and we will really try to get to those questions, because we want this webinar to be interactive and informative. So in terms of COVID vaccines in children, maybe I can ask Prof Pollard, so what do you think the evidence is at the moment and for COVID vaccines in children, and how effective are they going to be against the Omicron variant?
Well, I think the first point is with what are we trying to achieve with vaccinating children? And I think the answer is to prevent severe disease and to prevent MIS-C. And that is an extremely low rate in childhood. So when you look at the balance of risk and benefit, it is in favour of vaccinating children, certainly the over 12s. I mean, there are some children who will have severe COVID, more likely with certain comorbidities, particularly neurodisability. But actually, the rates are extremely low. But I think it is balanced in favour of vaccination. But it's important to say that in that context, that means that most children will have very little benefit because they will be fine anyway. They'll have mild disease. But I think overall, as an intervention, particularly if cost is not a question, which in a pandemic it shouldn't be, then we are balanced in favour. But that's in a naive population. And of course, today, whether you're in South Africa or the UK, particularly the over 12s, a very high proportion have already been infected, in which case the additional benefit of being vaccinated is likely to be much smaller. So I think it's unfortunately reached a very nuanced moment in the pandemic. If you're in a country which has managed to keep COVID out, which neither of our countries have, then it's absolutely clear to me that certainly in this older age group, vaccination makes sense. But once you've got the vast majority of children previously infected, it's much more nuanced about whether you think it's needed and whether it's urgent. I think overall, most countries are moving towards vaccinating children with at least one dose. There will be some children who have not yet been infected, and we don't know who they are. We don't have a good system for doing that at a population level. So in my view, it still makes sense to vaccinate in that older age group. But they are definitely not a priority in any population, because it's still older adults and adults with comorbidities who are the most likely to suffer severe disease. So I would be concerned if doses were diverted from that population to children who are at such low risk, particularly in a setting where much infection's already happened. As far as the other thing which people talked about earlier in the pandemic, the prevention of transmission, I think it's fairly clear in my mind that you may get some short-term benefit in preventing transmission while you have extraordinarily high levels of antibody. But as soon as antibody starts to decline, particularly with a variant like Omicron, or indeed future variants which will emerge, then it's unlikely that vaccines are going to be the major way of preventing transmission. So if we're not trying to use vaccines to prevent transmission, it's really about the benefit of the childhood population overall and preventing that relatively small number of severe cases and children developing MIS-C. It's even more difficult with the youngest age group because their risk of severe disease is even lower. So I think the strategy here in the UK was first of all to vaccinate those with health conditions, and then eventually those over 12 were included in that. And there's my understanding is that JCVI COVID committee is still wrestling with the questions over younger children.
Okay, that's great. And Waasila, can I maybe ask you what you think about immunizations then in the less than 1-year-old group, seeing that we had quite a few infections in the smaller children?
Well, I'll let the pediatricians answer on, the safety and, effectiveness of data for very young children for vaccines. But I mean, I think just to echo what's been said, we've not managed to vaccinate, the target of 70% of South Africans. I think we're struggling at about 40%. There's a lot of vaccine hesitancy and uptake has been poor. And I think our efforts should go to target and vaccination for those who are at higher risk, those who are over 50 or 60, those with comorbidities, to ensure not just that they get their primary series of vaccination, but to also ensure we get boosters to those who are at higher risk. I think the severity and mortality among children are quite low. We have had just under 1,000 deaths in children under 20, and perhaps, focusing the vaccine strategy in children amongst those who may have comorbidities, who may be at higher risk for severe disease, makes more sense.
Thank you for that. Prof, I'm going to ask, I don't think we're going to get away talking about vaccines and not touching on the topic of myocarditis in children. It's just something that I'm thinking about because I've seen a lot of the UK data coming out. So what is your approach in the kind of older child, first dose, second dose risk of getting a myocarditis?
Well, I think from the experience in the UK is that there hasn't been a huge amount of myocarditis with first doses, and I think that was also true in the data from other countries too, and that it was more associated with second doses. In the UK, second doses have been given. They were at least initially a longer interval between them. Perhaps that's associated with a lower risk of myocarditis if you extend to 2 or 3 months between the doses. But even if it does occur, it's extremely rare, and in most cases seems to be self-limiting. So far we've not seen a worrying level of myocarditis, but clearly it is there. It's described as an issue, and it's one of the things that needs to be taken into account in balancing the risks and benefits.
Okay, thank you so much for that. And Mignon, I don't know if you want to quickly just talk us through that SAPA statement, just a very quick summary of it, about what the SAPA saying about vaccines in children.
So we thought long and hard about this. As you know, we spent many hours putting this statement together, but I think the important thing is that it's exactly as Andrew said. We really want to share our vaccines with other African countries or people who don't have access to vaccines. We really want to, and I'm going bottom to top, we want to prioritize the older population and healthcare workers, specifically those with comorbidities. For high-risk children, we want to give not 1 but 2 doses of vaccine, and this was at the time when only 1 dose of vaccine was being advocated. And any child who is at higher risk of severe COVID. So not just to be giving the vaccine to all children who are well and running around, especially on a continent where we know that there's quite a lot of inequity. And the last time I looked, the general African continent was not very well vaccinated because often people did not have access to the vaccine. So I think if we were to prioritize definitely for the older people and for kids, those with comorbidities in the teenage group. And I guess obviously as it moves on and as we roll the vaccines out further, we may look at the younger kids as well with comorbidities. But if you've got a well child who is under 12 at the moment, who hasn't got any comorbidities, there would not be a huge rush to get them vaccinated. And I think we're all in agreement on that. So thank you for that.
That's great. Thank you so much. So we're going to move on to our long COVID questions. So Andrew Redfern is also part of the SAPA exec, and he's going to direct these questions. We haven't been able to get Dr. Whittaker onto the call. So we're going to direct some of the questions to Prof Pollard and to the rest of our panel. So please feel free for the rest of our panel to chip in if you can answer some of those questions. So over to Andrew.
Great, thanks, Marty, and thank you again to our panelists and to all of the people listening. So the first question was really just to go through what is long COVID and how big a problem is it in children? And so interested to hear perhaps some of the UK experience to start off with.
It really isn't my area of expertise. If Liz Whittaker is able to join us, she'd be very much the right person for that. And so I can only really make very general comments, which is that I think, as you were indicating, what is long COVID? And the problem is that it still remains a bit of a catch-all term for many different conditions. And obviously that varies from individuals who've been in intensive care and have morbidities associated with the intensive care admission, maybe some of those who've had severe COVID, where there's organ injury directly from that. And it includes people who have got the sort of post-ICU psychological syndrome, which we're very familiar with in pediatrics. And then, of course, there are a whole collection of other symptoms, which may be direct post-infectious inflammatory symptoms, as well as sort of post-viral fatigue type symptoms which individuals have. And really the research in this area has to try and separate out these different definitions of long COVID, so that we can make sure that the interventions are appropriately targeted. In my clinical practice, I've not been dealing with long COVID, so I don't have personal experience of it. And as I say, the long COVID clinics are trying to deal with this a very wide portfolio of problems that people suffer after COVID. I think optimistically with children, a lot of the symptoms that are reported that do persist do seem to settle over time. And I think that is a very positive view that I think is increasingly being seen amongst pediatricians. But as I said, I can't give you numbers because it's not really my area.
No, thank you for that. I did have a meeting with Liz a couple of months back towards the end of last year, and she was sharing some of the UK setup and system with us. And very much, I think, as you say, the good news was they do need support, but for a finite period of time, and the outcomes in general were good. Mignon, I don't know if you want to comment as well, but I'd also just encourage some people in the chat maybe to give their experience. I think there is a lot of anecdotal experience that we hear and encounter, and in fact, I haven't seen a lot of statistics around this or hard data. So I think we do need to maybe collectively as a group, through the combined wisdom of not just the panel but the attendees, just try and do some myth busting or get a sense of how big a problem this is.
So if I can just comment while people are thinking up their questions, I had a long discussion with Kate Webb last night, and as you know, Kate Webb is a rheumatologist, and she also has an interest in chronic pain and chronic fatigue syndrome, and there's a lot of overlap in this sort of area. I think the important thing about managing long COVID is realizing that it really is a condition. Also to realize that you need a multidisciplinary team, and often you need allied health professionals to help you with that. So if you've got a physio who's got an interest in how to manage your day, also to have address parents and the patient's expectations, in that it's not something that's going to go away quickly. It may take 6 months to a year to actually get through. There's quite a lot of research happening in all kinds of interesting spheres, such as platelet stickiness. There've even been some papers that I've been reading in the last week about plasmapheresis to try and get rid of abnormal factors. That's obviously very dramatic, but I think the bottom line is to be assuring that it does have a positive outcome in the majority. It does take time. You need a big team of people. The adults are using quite a lot of SSRIs as well to deal and to help with the mood stabilization. You may need a graded rehab program. And I think it's important to do it as a team, but to be positive about it, in that, there is improvement in children, there is a good prognosis. But I think it is something that's being seen specifically in sort of teenage children. There's no magic cure. I think, unfortunately, there's no pill that you can take and say, well, if you take this pill 3 times a day for a week, you're going to be a lot better. But I agree with you, Andrew. We need a multidisciplinary team. We definitely need teams from across the world to actually share their expertise and input. And I think there's a lot still to be learned about long COVID, but it definitely is a condition. So thank you for that.
I wanted to come in there, and unfortunately, so we're doing a study at the NICD on long COVID, and we're following up people for up to a year after their COVID infection. And unfortunately, we didn't recruit any of the pediatric population, but I just thought it would be interesting to share some of our data. At 1 month, 89% have persistent symptoms after hospitalization. At 3 months, 66%. And at 6 months, 59% of people post-hospitalization still have persistent symptoms. The most common symptoms being fatigue, headache, brain fog, and shortness of breath. And also interestingly, the prevalence of persistent symptoms differed if you were hospitalized or not hospitalized. So 66% of those who were hospitalized had persistent symptoms at 3 months and 38% non-hospitalized. And we also did some multivariate analysis of risk factors for persistent symptoms. And it was older age, female sex, non-white race, having been in ICU or ventilated, having comorbid conditions, and having more acute symptoms during your acute COVID. So 4 or more symptoms during your acute COVID infection, or predisposed you to developing long COVID. Unfortunately, that's not in the pediatric population.
Thanks very much for that perspective, Waasila. That's very interesting. And Anusha Lachman is also one of our panelists. She's a child and adolescent psychiatrist at Stellenbosch. Anusha, before we move on to mental health issues, just do you have any experience or comment regarding the long COVID?
Yeah, thank you for the invitation. I was just going to come in on exactly that. So I was part of that call with Dr. Whittaker and Kate Webb at the time, and also Dee Abrahams. And what we anticipate is that there will be more sort of fundamental neuropsychiatric symptoms that we are seeing that are not necessarily physically holding out, but definitely we're seeing children complaining of not just the fatigue and the pain, but their interpretation of the pain. So there's a lot of anxiety around that. And again, to just reinforce what you're saying, that obviously we need a multidisciplinary approach to tackle this. We haven't done any formal screenings, but I can say that we were part of the coast-based study with Oxford, looking at sort of how adolescents and children and their parents were managing the lockdown in 2020 through to 2021. And these were not children who were COVID positive, obviously at the time, but basically during the extreme lockdown and when they had to reintegrate to this rotational basis of school, and the sort of wavering and relaxing and reinforcing of the restrictions. And what we do have for preliminary data in South Africa, which we're neatening up at the moment, is high rates of anxiety. Lots of what looks like ADHD symptoms, but they're not actually ADHD symptoms. And maybe we can talk a little bit about that in terms of the mental health presentations. So children are super anxious. They are not concentrating. They're quite distractible and edgy. And so whether that is part of the anxiety that's, sort of seen throughout this recovery phase, now that they're having to go back into the normal, which is actually not normal for most children that didn't start grade 1 normally. We'll wait to see, but that's obviously something we're keeping an eye on. And we definitely believe there is a long COVID neuropsychiatric sort of cluster of symptoms, if I can say that. So we're wanting to obviously look at that a little bit better.
Great, thanks Anusha. Just keeping an eye on the chat, but then do you want to then carry on just with, not specifically about long COVID, but just in general, what has this pandemic done to children and adolescents in terms of their mental health?
Thank you. That's such a loaded question because, I've been listening to the last 40 minutes about how the children are doing okay. And I'm here to burst that bubble and tell you they're not doing okay from a mental health perspective. I think that one of the biggest issues is that we focused a lot on the loss in terms of physical loss and grief. So a lot of parents have died, a lot of grandparents. We have a huge population of children in South Africa that are really brought up by their primary caregivers who happen to be grandparents. And we saw a lot of them die in the last 2 years, including extended family members. And we also have primary caregivers who have lost partners, so spouses. And so the adults haven't been really resolving or dealing with the grief very well. And how that translates, because the children are part of this relationship, is that the children are not doing well. And while we talk a lot about the grief in terms of physical loss and death, I think what we're actually seeing now is the loss of normalcy. That's really hard for children to get back to. And so what have they really lost? I think in the last 2 years, they've lost what is essentially their normal developmental trajectory. So they haven't been engaging in peer interactions. They haven't been socializing. They've been really isolated at home. Home is not always a safe space in South Africa. And I think we have to remind ourselves of that, especially children with developmental delays, autistic children, children who have mental health issues. It's actually more vulnerable for them to be at home, often with the perpetrators at home, or actually being at the receiving end of abuse because they are behaviorally difficult to manage. So we've really seen a spike in presentations to mental health services for two things. One is behavioral patterns. So children are either more aggressive, more needy, more clingy, and parents are finding that difficult to deal with. And secondly, anxiety. So the anxiety is just skyrocketed. Children needing constant reassurances. We're seeing clinically, obviously, we haven't screened that effectively enough, but higher rates of obsessional presentation. So children really having ritualistic type of behaviors, especially higher functioning children who find their environment quite out of control. So the only way they can actually control the unpredictability of it, one day you isolate, then you don't isolate. Then we're back to school, but we're not quite back to school. Then we're restricted in our lockdown, but actually you can have a party. But they know you can go back to school, but you can't, but you can have a 500-person funeral. So it's very difficult for them to make sense of that. And so this kind of flux of unpredictability leads children with a vulnerability to anxiety to become more rigid, more inflexible, very difficult to shift. And so that's hard. That's hard to adjust in a school situation. It's hard to adjust in a peer interaction and also at home. And so what children are presenting with then are really mental health difficulties in terms of anxiety. But just to remind you, the anxiety doesn't look like it does in adults. So it's these kids who are constantly needing the reassurance, but also not sleeping well. So they're super anxious and they have poor sleep. And so what we then do is we say, let's give them melatonin, let's medicate, let's, do all of that. But you're actually missing the fundamental problem here, which is that they're anxious at baseline. Hypervigilant, hyper-aroused, and the communication is poor from adults who maybe don't know how to support and who feel unsupported themselves. Also from pediatricians who don't know what's the right language to use necessarily, because children get asked, are you anxious? Are you sweating? Does your heart rate increase? It's not like that. It's how are you feeling? Are you fearful? What worries you? Those are the kind of words maybe that are a little more sensitive to the anxiety. So just from that. And I guess I have to end it with saying that not all children have been affected in the same way. We have a disproportionate burden of disease because of the socioeconomic drivers, which we can't ignore. But even in children who are from higher functioning or better social circumstances, they have had parents who are first frontline workers who've also been severely affected by that. And again, it's the not knowing if my parents going to hospital to treat other children or other people are going to come back alive or not. So this conversation needs to happen, obviously, in a more nuanced way.
Thanks, Anusha, and welcome to Liz, who's just joined the call. Anusha, another loaded question for you then, and that is, having just described what you've described, some things are obviously, it is what it is, COVID is what it is, but what would your suggestion be to the pediatric community represented here in terms of what can we do? And I say it's a loaded question because we know, or I know firsthand, the pressure that child and adolescent services are under. And so what would be the best thing to do? What would your advice be to people in terms of what can happen at primary care versus what needs referral, that sort of thing?
Thank you for that, because it's actually not that loaded. I think we have to dispel this myth that everybody or every child that presents with a mental health concern needs to be up-referred to a super specialist, or to a mental health service. Sometimes it's about asking the question that you can actually provide the answer to. So asking a child, if you're worried that you're going to die from this, are you scared? Are you not sleeping that well? Is it hard for you to concentrate? None of that should equate to, do you have ADHD? Let me send it to the psychiatrist. Do you have an anxiety disorder? Let me medicate you with something. Because I think my advice to primary healthcare practitioners and pediatricians is that you need to open the communication. Very often this conversation is not happening at home. And so children need that opportunity to be able to say, in a very open-ended question, what worries you? You might be surprised that the answer is, I'm worried about mom, or I'm worried about what's happening at home. And so we have to be less fearful to ask that question, because you might be surprised that you are actually quite equipped to manage that effectively. And children are simple, as you know, so they're going to ask very simple questions. So I think we must not be afraid to screen, and we must ask simple questions like, are you afraid that someone is going to die, or that you are going to die? Or do you want me to explain to you why this may or may not have happened to your grandma or your mom or whoever it is? Because I think that if children get a simple explanation, they're pretty resilient after that. But if they're left to their own devices, they come up with the most bizarre, catastrophic ideas of how to make sense of it. So at a basic level, just ask the question. Children just need that open line of communication, and that holding. It doesn't really require a pull most of the time.
Yeah, thanks for that. That's sort of a great answer in terms of just common sense, and I think you're so right in terms of just that awareness is the first thing, and that it is just a case of, for children in general, with lots of things, just having good ways to communicate with them and to really listen to them. I think the last thing I wanted to ask was just any particular resources. Obviously, lots of parents are looking, lots of GPs and pediatricians are looking. They're aware of the disruption in schools, the so many challenges that are facing young people. We're seeing, unfortunately, more sort of parasuicide and suicide attempts. Any resources that you would say, this is a clear description of the kind of common sense things that you've just said, and to raise awareness, or that we can give parents?
So I think that if you look, we've been really lucky in South Africa, because we've had a number of psychologists, for example, and social support workers who have put out really great online resources. So, for example, if you Google in COVID support for children South Africa, really lovely things will come up from psychologists. Off the top of my head, Garth Newman Psychology, which is a website of a psychologist, has printed out 3 books, which are available in really culturally specific and sensitive ways for South African children. Athol Williams, who also has a foundation, also has printed out online resources in all languages available for download, to take children through that kind of anxiety, but in a way that is specific in the South African context. And the WHO also has a beautiful online resource there in terms of story picture books that parents can access, which is really helpful because it explains it in a cartoon way, in a non-threatening way. So it literally is just about Googling it. I also know that UCT, Children's Institute, also has a pamphlet that you can download for free in terms of what are the core red flags for mental health. And those are all available freely online.
Cool, thanks Anusha. And I think we'll try and put some of those links in the chat as well. I am going to go back to Liz now, and Liz, welcome. So delighted that you could join us.
Sorry that I'm just a bit all over the place. Apologies for my very tardy nature.
No worries. I also was struggling to get in before the meeting. So just to introduce you, Liz, we have met briefly on a previous call, but I know you do have links with South Africa and with many of our South African PEDS ID colleagues. So Dr. Liz Whittaker is a pediatric infectious diseases specialist based in London at Imperial College and at St. Mary's. Was one of the original people on the planet to discover and describe Miss C, which has got to be something to be proud of, as well as is extensively published and has lots of other interests, particularly around infant immunity, and more recently COVID and its various phases, one of which is Miss C and one of which is long COVID. So we did rather unfairly direct some questions at Prof Pollard, who graciously did his answer. But perhaps you can just give us your sense, because I know you have been involved in terms of the UK at a national level. Just what is the extent of the long COVID problem? What are you seeing? And we've had a couple of questions in the chat, so I'm going to try and just pick up a couple because I have limited ability to multitask. So I've been trying to keep a chat, but just maybe give us a definition of what is long COVID, and can you have an asymptomatic period after your acute COVID infection and present later?
Absolutely. So I think it's also really timely coming after Anusha, because there is so much it's entangled in the fact that our young people have had a terrible time during the pandemic, which makes any persistent symptoms harder to manage rather than being the cause of their persistent symptoms. I think it's really important to get that correct for the families and their young people. So the definition of post-COVID syndrome or long COVID is persistent symptoms after 12 weeks. But we would encourage young people who are experiencing persistent symptoms that are in particular affecting their function, going to school, their enjoyment of extracurricular activities, to seek medical support prior to then, and for paediatricians and primary care practitioners to be open to the fact that they don't have to wait to 12 weeks to investigate and rule out other conditions. You will hear terrifying numbers, like 1 in 7 children who are infected have long COVID and various things like that. And I think that overstates the true nature of this. So I think lots of young people are struggling and are experiencing persistent symptoms, but a very tiny number are experiencing really debilitating symptoms for which I would consider it an emergency, that they're not able to go to school, that they're not able to fulfill the normal activities of daily living. And so for context, we've had our clinic open in London since April. We've had 90 children who've come through the clinic, and they come very, very, very diverse backgrounds, and they are often really debilitated. As I said, they're struggling to get off the sofa, never mind go to school, and they cluster into different symptoms. So a very classic chronic fatigue, headaches, brain fog, tiredness type group. There's a group of young children who present with kind of rashes and abdominal pain and very much seem to have an allergic component or a mast cell dysfunction type area. And then another group who present with some neurology, and they are a very tiny number, but they make a lot of media splashes because they're quite scary, and we don't see many of those. What we don't see, I think, is what's described much more in the adult sector, which is following severe disease or with an autoimmune component, are the adults who get myocarditis, pericarditis, clots and things like that. And thankfully, despite extensively and over investigating lots of children, we haven't found evidence of this. It doesn't mean it doesn't exist, and we should be aware of looking for it, but it isn't a common presentation. And most of our young people didn't have a severe episode of COVID to start with. They may even have been asymptomatic. And one of the really interesting research questions is, what is the relationship with PIMS or Miss C? Because they do start to develop symptoms kind of 4 to 5 weeks later. And is there an underlying immune component to it? I can keep talking, but I'll hold. Yeah.
I'm sure you can, and we'd love to keep listening. I'm going to keep an eye on time, but I do want to ask, so just related to the waves, we had a discussion at the beginning of the meeting around the different clinical and epidemiological features of the waves. Any comment from your side in terms of the differences between the different variants, and also potentially the role of vaccination?
I think that's a really interesting question, and it's hard to unpick because the children who became unwell with Wuhan variant or with early variants weren't tested, struggled to get traction and weren't recognized as having a problem for quite a long time. And I think the longer you're suffering with these conditions, the longer it takes to get better. So that can make it look more severe with a different variant. And so I don't know that it's that straightforward to unpick. We certainly have seen a little cluster after each wave of the pandemic, and I don't know that we could say epidemiologically whether there is a difference, but the CLOCK study, which is a massive prevalence study in the UK that I'm a co-investigator on, is trying to compare each variant with the others, but so that data will come. In terms of vaccination, it's a really mixed bag. So there is early data to suggest that if you decrease infections, which we know vaccinations do not prevent infection, but can decrease it, then it seems natural to expect that you would see a decrease of the complications of infection, which would include long COVID. And some people who experience long COVID describe an improvement with the vaccine. We are hopefully working with a Dutch group to actually do a trial of that, which will be now at this point, because JCVI and other groups have introduced vaccination in different ages, will be an observational study rather than a randomized trial to try and explore how tightly related those things are. But I think that's a very uncertain thing, and it's not something that we would base a vaccine policy on because we don't have enough data yet. So for our patients, we say they should take whatever vaccines they're eligible for, that we wouldn't recommend not having it because of a worry about long COVID, but also not to expect it to be a panacea.
Cool. We touched briefly on some of the theories, some of the research coming out around what might be going on, maybe with clotting, platelets, this sort of thing. Just your take on...
Yeah, the microclots data is very interesting, although it has predominantly focused on an older age group who are more likely to have an autoimmune phenomenon. I think it's really important that we explore it. And what we say to families is that the regular tests that we can do may all be normal. That just may mean we're not measuring the right thing. And what's important is actually helping you to manage the symptoms you have. Very reluctant to start doing interventional trials of treatments until we have better data. So some of the hypotheses, autoantibodies, I think is a very realistic one. We know that the spike protein on the SARS-CoV-2 virus can induce autoantibodies, for example, to interferon. So it may be reasonable to think that that's part of the pathogenesis for some of these young people. It may be really exciting, I think, for anybody who works in medically unexplained symptoms. We may actually be able to explore chronic fatigue and ME in a much better way as a legacy of COVID. So I think try and see the silver lining of everything that's going on in the pandemic. But to be honest, we don't really know. I think what's most important for us, the pathogenesis is important, but also good diagnostic markers and possibly prognostic markers are things that we're working on. So we're including children in the DIAMOND study, which is a big diagnostic study we have across Europe, in collaboration with a group in NIH in the US. So I don't think we know at the moment. And our priority has been on supporting these young people to get better, but trying to include them in research trials. It's actually really hard to get funding for pediatric studies, as always, because they make up such a small proportion of the big population that affects the healthcare system, but are so important to get it right in this age group. So I'm sure from this mental health perspective, if you kind of make a mess of it at this age, it kind of has lingering effects through adulthood.
Absolutely. Maybe you mentioned it, but maybe you could just talk us briefly through kind of the approach that you've adopted in the UK. And so what I'm saying is, what is the management of long COVID? Just the key sort of fundamental principles.
So the most important thing is to rule out a clot or a heart problem, and actually really basic tests such as a 1-minute sit-stand test or a 6-minute walk test with heart rate monitoring and desaturation, just to make sure that we're not missing something that we haven't seen, but we don't want to miss it when it is there. And then we do a fatigue screen. So we use the NICE chronic fatigue blood test, which I'm happy to share with anyone, but it's common sense, good general pediatrics, celiac disease, vitamin D, iron, etc. like that. And once they've all been ruled out, it's then exploring which bits of their symptoms are most affecting and then doing targeted work on those. And so there may be some minor symptom management tools. So there's a lot of children who have POTS, for example, so kind of increasing fluid and salt, all those usual things. And then we have a series of self-supportive management tools in the forms of information leaflets. Very happy to share that. And we do group sessions. So we do lots of getting a lot of young people together on Teams or Zoom with some therapists and their families and talking through what they found has worked and strategies that they can use. We found they have terribly disordered sleep, so it's all quite common sense. And then physio and OT can also be involved as well. The psychological support to help them manage their symptoms is key. And that they nearly all say that the minute somebody believed them, they actually started to feel that they could start to get better. So just really echoing what you were talking about when I joined, is that, it doesn't really matter giving somebody a label. If it's a label that helps them reach the appropriate support and start on the pathway to get better, then is that a bad thing? I don't think so.
No, that's great. Thanks. Okay, I'm going to hand back over to Marty, who had now some more questions. And I'm just going to squiz through the chat and see if there's anything we need to cover.
Okay, great. Thank you so much, Andrew. Thank you so much, Liz. So I just quickly want to ask Mignon. She's been dealing a lot with the media and going back to school and social distancing. So I just wanted to summarize for us, what do we need to know if our parents are asking us about their children going back to school, and what should be the rule in the classrooms?
Thank you very much. So I think Anusha hit the nail on the head. School is not just about education. And I think we've learned that through this whole pandemic, through every single wave. School is about nutrition. And even in the UK, I saw a poster saying it's every child's right to get appropriate food during a COVID pandemic. It's about physical safety. So we know that if kids are at school, then the chances of them being knocked over by a car, either on the pavement or on the road, is far less. It's about psychological safety, and she really described that so beautifully, as did Liz. It's about sexual safety, because we know that in South Africa sexual abuse is a big thing. And so education is almost bottom of the rung if you look at all the other issues. And so we've had lots and lots of discussions. We've had ministerial advisory committees. We've tried to advise the government that it's not just about one issue, it's kind of a package of care. And I think pediatricians have heard about a sepsis bundle or sepsis package, and in the same way, going back to school is the same. So what we're saying is, if you have a class of 60 kids and you can't physically distance them 1.5 meters or even 1 meter, are you really going to be too worried about distancing them at all? If you look during the school holidays, I watched people on the beach, I watched people outside, they definitely were not distancing themselves 1 or even half a meter. Masks, if you can, and we know that little kids can't wear masks. Our government ruling is 6 years and upwards. I noticed in the US, they've actually got 2 years and upwards. I challenge anybody to get a 3-year-old to wear a mask consistently and properly. Ventilation is a big thing. So if you have a classroom where you can open the windows, open the door, and we've been very lucky during this wave. South Africa has had summer. We haven't had the cold winters and the snow and all the kind of stuff we've seen on television overseas. Hand sanitation and just being sensible. If your kid is sick in the morning, don't send them to school, because during this Omicron pandemic, the chances are that they've probably actually had Omicron. The story about alternate day schooling, I think, is something, and I've seen it in the chat group. There have been a few people who've asked about it. It really is crazy, and we don't want to criticize anybody, but I think we really need to try and get back to daily schooling, because this COVID is not just been around for a year or 2 years, it's now going on 3 years, and the chances are it's going to continue long term. So we're going to need to learn to live with it, much in the same way as influenza. If you've got flu, you're not going to go to work or go to school with a cough and a cold. You're going to try and rather stay at home. But I think we need to be sensible. But we need to get kids back off the streets and back at school, and we need to try and get them to stay calm and not feel anxious about what's happened to their school buddies, what's happened to their teachers, what's happened to their friends. And so we are really pushing for kids to go back to school under as normal conditions as possible. And we know in South Africa, sometimes the safest place, if your parents are at work, is for you to be at school. So that's our thinking. I agree with everything in the chat group. Should kids not be going back to school? If kids are mildly sick, should they be going to school or not? I think we need to start treating this. People are saying moving from a pandemic to an endemic condition. But for me, the worst crime is not getting kids educated. In South Africa, a country where we already have so many challenges in education and so many children who have needs, we really need to get the kids back to school. And I think we're all on the same page as that. Thank you.
Great. Thank you, Mignon. So I quickly want to address one of the questions in the Q&A, and if maybe Prof Pollard can comment on this. So do you think there's any chance we will still discover some long-term adverse effect from the vaccine that has not yet been reported? And that in terms of balancing the risk of vaccinating a teenager with very low risk of severe COVID. I think we've touched on this, but maybe just in terms of the long-term adverse effect, is there still a chance that we will discover some of these?
Well, I think there's two answers to that question. First of all, we have the experience of vaccines going, particularly with improved surveillance of vaccine programs over the last 50 years or so, that almost all side effects that occur are detected within about a month. And certainly if you extend that window to about 3 months, you would pick up everything really that's been described as associated with vaccines as a side effect. So just from historical experience, you would say it's highly unlikely we're going to discover something much later. In addition, we now, for COVID, have, I think, the most incredible surveillance that's been done for any drug or vaccine ever, with the whole world looking in great detail about the products that are available on the market. Now we're approaching 10 billion doses out there. And for the leading technologies, the surveillance has been going on at population levels for around 2 years. So I think we've got pretty good evidence that there aren't long-term side effects that go beyond those first month or so with these vaccines. The trials themselves obviously are the highest quality data, but they're too small, even though they have tens of thousands, they're too small to pick up very rare side effects, but that will have picked up the common things that occur. And so it's really this population surveillance, which is at a level that's unheard of before, that gives me quite a lot of confidence to say, I think it's highly unlikely that we'll pick up anything else. But also we've got that historical precedent that you tend not to see things that occur later than the first weeks afterwards.
Thank you for that. I now want to ask a couple of questions in terms of being a healthcare worker and trying to move on to the new normal. So, I remember doing viral panels in the ICU, getting every second child back as a rhinovirus, going through those waves of infections. And then sometimes you decide to think, okay, maybe this rhinovirus is actually significant, or maybe it's just a coincidental finding. So when do you think we will look at COVID-19 like that and just say, oh, it's okay, we just move on? Do you think we are going there, or are we far from that?
It's a really good question. Of course, it's the most important one in terms of planning from here on is what will COVID be like going forwards? And it may be for pediatrics that it's an easier answer than it is for the rest of medicine. The reality is that at this moment, we're doing, certainly in high-income countries, huge amounts of community testing and picking up people who are actually well and have mild infections. And that in itself is not of great importance clinically. So what we have to move to next is clinically driven testing. So we need to get beyond this extensive community testing. And we do need to be testing people who come to hospital with a clinical illness. We need, particularly in settings where you've got vulnerable children or adults on a ward, to have testing to know that there isn't going to be a transmission event in the hospital, that we can try and manage the nosocomial things. That's the transition phase that we should be moving into during this year, where testing is clinically driven and not asymptomatic testing. And I say that particularly thinking about the impact of asymptomatic testing on schools. It worries parents, it stops children getting into school. It has an impact on classes in many parts of the world, school closures and nursery closures as a result of that, for an illness, or at least a virus that has a very little consequence for most children. So I think in the sense that we've got this transition period to move over, that's where we're going to start learning a lot more about what actually we need to be worrying about, whether, as you say, it's going to be so commonly just an incidental infection that we start thinking in pediatrics about this as a very rare cause of severe disease, like some of the other coronaviruses that currently exist, but actually almost never significant in childhood. I don't think we've quite reached that stage yet, but that could be a future for pediatrics. For wider issues in medicine, I think there's two possible ways we could go. Population immunity globally has grown hugely, and that will drive Omicron and then future versions of the virus to be much less likely to cause severe disease. But that could end up with cycles like with RSV and with flu, where either RSV is a susceptible population that builds up because a baby is being born, and flu, it's more waning immunity and a new variant. that leads to a winter peak. So we could have winter epidemics in the future when people are a bit more clustered together, immunity's waned or new variants arrive. And that's going to be a problem for people who are non-immune, and will always be some in the population, and frail individuals with other health conditions, which even with a mild infection will tip them over the edge. So that's going to be really important for the health system to understand, because we'll need to build enough capacity to be able to cope with that. And possibly if we have good enough warning that waves will happen every year, we could get to a point where we vaccinate with a sensible variant vaccine at that time. But it's also possible, as you, I think, are implying, that it becomes more of an endemic disease rather than seasonal epidemic disease, where it's there in the background perhaps throughout the year, with the immunity that we have becoming quite spaced out, where some people are very immune and some not so immune, and you just have some ongoing transmission, which for most people who have some immunity will just boost their immunity. But again, it will find some of those individuals who are susceptible to more severe disease. And what we're going to have to work out clinically is who those people are and how best to manage them. How do you get antivirals in? Do they need monoclonals? What's the optimal intensive care approach? But this is all arm waving at the moment, because we don't quite know exactly how this will move forwards. Wouldn't it be great if this direction of travel for Omicron, of being a virus which seems to be milder, is something which is, we're forcing on the virus through population immunity, that it'll become like other coronaviruses where most cases are very mild.
We hope for that. So I maybe can direct the next question to Liz about, as a healthcare worker and having vaccines, do you predict that we're going to have to get booster vaccines every 3 to 4 months? I mean, some of us don't always feel that well after a vaccine. Is it something that you predict that as healthcare workers and high-risk people, we're going to need a booster like every 3 to 4 months?
This is really probably more Andy's question, but I have to say, separately, as a healthcare worker personally, I don't feel that's necessary for me, in particular as a slightly younger woman. I had my booster when Omicron started to come through, and I still got Omicron at Christmas, and I was as unwell with it as you expect, which is not very. And so I feel that we probably need to have a slightly more targeted approach to who really needs boosters, and to try and think. We do know much more about what risk factors exist, and I'm not sure if there's a huge benefit in giving boosters to young people who are not necessarily going to benefit, particularly in the context of how much of the globe is unvaccinated, which I feel really strongly about. I felt really guilty having my booster. I really didn't feel like I needed it, and I really don't think it gave me any benefit. So I may be skewed. I think Andy is in a better position to comment on policy or what's appropriate, just because of his position in this regard.
Yeah, I mean, I think I agree completely with what Liz said. I wasn't sure she was implying that I'm older and therefore I'm more likely to need a booster. No, I mean, I think the real issue here is making sure that there's access everywhere to vaccines, and that is increasingly the case. And I know in South Africa the major problems with hesitancy, but there's less of a problem with supply than there was previously, and so there's lots of work to do. But that's not the case everywhere. There are many countries, particularly across the African continent and some in Latin America, where it is still a problem of supply. And so I think that has to be the absolute priority, is to make sure that where countries are able to deploy vaccines, that the doses are there available, and that there's support to try and address the vaccine hesitancy issues, so that those people today who are still in the groups who are vulnerable and at risk of dying do have access to vaccine doses. I mean, we look at where we are today in 2022, and people will still die this year. I mean, unfortunately, global mortality is falling quite significantly, although there's a little bit of an uptick with Omicron at the moment, but not huge. But it is much lower over the last 12 months than it was a year ago. But the sad thing is that most of those deaths are still the same people. They're still older adults and people with health conditions all across the world who are unvaccinated. So I think, like Liz, it feels shameful that we're still in this position today. We know what the right intervention is, and we have the public health tools to deal with it, and we still haven't done so.
Sure. So we should probably start wrapping up just one more question in the Q&A. And please, if there's any more from the participants, please post your questions. So should we vaccinate or boost children who have parents that have comorbidities? So maybe again to Prof Pollard.
Yeah,
and maybe
I think this is really tricky because I don't know that it's not going to prevent them from becoming infected. I think we need to think about other mitigations to protect their parents and do what we can to protect them. And we're very fortunate in the UK that we have many other options in terms of oral antivirals that are coming through and monoclonals that are available in the community for those who are vulnerable. And so those kind of pathways probably deserve to be made affordable and available in many contexts, rather than trying to give additional vaccines to children that may make people feel better, but are not necessarily doing a lot in terms of protecting their parents. And so overall, I think protecting the bigger population and having sensible policies around how we decrease transmission is going to have a much greater protective benefit for their parents than vaccinating the children over and over again. But I don't make policy. There's probably a reason. Yeah.
No, I agree with that. I think the only argument you could make, and we do have evidence that the very high antibodies you get with a booster will reduce your infectiousness or your chance of becoming infected with Omicron in the short term. So if you were able to deploy vaccines just as a new wave was coming, and you knew that the rise in antibodies was going to reduce the risk of infection, you could provide added protection in a cocooning strategy. Cocooning strategies, generally speaking, have not been hugely successful. They're very hard to deploy at scale. So I can see a short-term benefit, but we wouldn't expect those immune responses to stay high enough to completely block infection. And as Liz said, you can have 3 doses and still get Omicron. So it doesn't make the risk zero, but at least in the short term, it would reduce it. I'm just not sure from a policy perspective how you deploy it in a useful way. And today, we're not really worried about Omicron now because that's going in South Africa. The real question is what about the next variant? And we have no idea whether that booster is going to help us with the next variant.
That's great. So I don't see any more questions, so I'm going to use the opportunity to ask one more of my own questions. Just in terms of testing. So I think as a healthcare system and government, or maybe that happens in private as well, I feel that there's still a lot of patients that we've delayed procedures because they've tested COVID PCR positive. And especially if they need surgery, and the surgeon still seems to be hesitant and is asking for repeat PCR testing on those patients. And we sometimes have these patients that test positive for 6 weeks, 2 months. And I'm asking whether a strategy going forward, whether antigen testing would be a better guide in terms of infectivity than doing PCRs on these patients.
So we've just finished a study called LAVA-2 in children, which specifically is answering this question. So hopefully we'll have that data quite soon. But certainly the aim was to demonstrate that lateral flow tests would be an alternative to PCRs. And in our practice, actually, that's what we do. So we don't do recurrent PCRs, we do a lateral flow. And actually, we're increasingly just putting the surgeons in appropriate PPE and cracking on with it, because there are so many delays behind the surgery that unless it's a major surgery where there might be a negative impact of the child being infected on their outcome, we tend to not get hung up on it too much. So lateral flows are already in practical use for us in that context here.
Yeah, I would agree with that. I think the important point you made is not during the acute infection, that unless it's an emergency.
Obviously, if they're symptomatic, that's a different thing. But we're presumably talking about asymptomatic children where you've picked up an incidental infection. But the PCR being positive for long periods, we have to really be pragmatic about that. And we are increasingly using lateral flows as part of our flow for children on wards, particularly thinking about how we get children from accident emergency up to the wards and things without delaying because of their tests positive and things like that.
That's great. Thank you so much. I don't know if any of the other panelists has got something to add or something to ask each other at this point. Okay, so I just really want to thank you all again, and thank you to all the attendees that joined us. It was really, for me, a very informative and fantastic session, so thank you for that. Just two things in terms of the SAPA webinars. They are CPD accredited for SAPA members. It's the beginning of the year, so please become a SAPA member, and we will keep you up to date with what events are happening around SAPA. So go and visit our website, and thank you so much for joining us. The CPD points won't be sent to you as a certificate after every session anymore. It will be sent to the HPCSA, and they will load it automatically onto their portal, which I think is a fantastic way for us as healthcare workers to easier keep track of our CPD points. So thank you so much, and I hope you all have a lovely evening. We will see you at the end of February, last Wednesday of the month, and we will talk about low respiratory tract infections and when does a child warrant further investigation. Thank you so much for joining us.